Now coming to the pathogenesis of MASLD. So the primary problem in pathogenesis, or which results in steatosis or accumulation of fat within the liver, is insulin resistance. Not even in diabetic, even in non-diabetic individuals, they have shown reduced insulin sensitivity even in non-diabetic individuals. So primary problem here is insulin resistance at the level of liver and the muscle. So what happens is there is increased insulin resistance at the level of adipose tissue also. Okay. So because of insulin resistance, what happens? There is increased lipolysis, there is increased breakdown of the fat. So as we know, insulin is essential to reduce lipolysis. So then there is insulin resistance, there is increased fat breakdown, there is increased lipolysis, there is increased free fatty acid production, okay, which is going to result in lipotoxicity. Another important is there is, because of insulin resistance or because of obesity or other genetic factors, there is also adipocyte dysfunction. So what happens because of adipocyte dysfunction? There is decreased anti-inflammatory adipokine secretion. That is, what is anti-inflammatory adipokine? Adiponectin and IL-1. So there is decreased anti-inflammatory adipokine secretion, and there is increased secretion of pro-inflammatory cytokines like TNF alpha, TGF beta, IL-6, leptin, etc. So there is overall imbalance in the inflammatory markers, right? One, because of insulin resistance, there is increased lipolysis and increased free fatty acid production, and because of adipocyte dysfunction, there is decreased anti-inflammatory adiponectin and increased pro-inflammatory cytokines. Now what happens because of all this factor? So as I said again, because of insulin resistance, there is increased lipolysis, and because of genetic factors, dietary factors, obesity, again there is adipocyte dysfunction, and there is increased adipose tissue, of course, in obesity. So all these are going to result in increased free fatty acid production. So because of insulin resistance, what happens? There is increased uptake of free fatty acid from the serum into the liver, and in the liver what happens? There is increased free fatty acid, and this increased free fatty acid is getting converted to triglycerides and is getting deposited. Usually what happens? Triglyceride gets packed in the VLDL molecule and is getting secreted in the serum. But here again, because there is insulin resistance, there is decreased VLDL assembly, and there is decreased beta oxidation, and there is increased de novo synthesis of lipids. So all this is going to cause increased free fatty acid and increased triglyceride deposition within the liver, ultimately resulting in lipotoxicity. Okay. So what this lipotoxicity does is, it is going to cause more of mitochondrial dysfunction. Apart from lipotoxicity, as we said, there is increased production of pro-inflammatory cytokines from the adipose tissue. So again, these pro-inflammatory cytokines are going to result in inflammation in the liver, and it is going to result in mitochondrial dysfunction and endothelial reticulum stress. Both of this is going to result in increased reactive oxygen species. The scavenging of the reactive oxygen species becomes impaired because of mitochondrial dysfunction, and there is increased reactive oxygen species, which is going to result in further inflammation, apoptosis, fibrosis, and ultimately is going to result in NASH. This is a older version, so now we will rename it as MASH. Okay. So ultimately, this is the pathogenesis. So basic problem is insulin resistance, and there is adipocyte dysfunction. Ultimately, there is a lot of triglycerides produced in the liver, and VLDL assembly is also reduced. So triglycerides gets accumulated in the liver. All these inflammatory cytokines are going to result in mitochondrial dysfunction, hepatic iron deposition, and all that is going to result in increased reactive oxygen species, ultimately resulting in inflammation and fibrosis.